let's summarize the pathoanatomy of cardiogenic shock. Cardiogenic shock occurs when there's either a systolic or diastolic dysfunction of the heart's pumping action that decreases cardiac output. Systolic dysfunction occurs when the heart is unable to push blood forward. There's an interruption in the left ventricle for it to push oxygenated blood to the rest of the body. When the dysfunction to push blood forward, stroke volume decreases. With a decrease in cardiac output and a problem with oxygenated blood moving forward, cells in the body do not receive oxygen. This causes a decrease in tissue perfusion that leads to impaired cellular metabolism. A myocardial infarction is the primary cause of systolic cardiogenic shock. When it comes to diastolic dysfunction, this is caused when the heart has a problem filling. Blood begins to back up into the lungs. This causes an increase in pulmonary pressure. The increase in pulmonary pressure causes pulmonary edema, which leads to a decrease in oxygenation. This leads to a decrease in tissue perfusion and impaired cellular metabolism. Cardiac tamponade is a cause of diastolic cardiogenic shock. Unfortunately, there is a 60% mortality rate for a patient with cardiogenic shock. Another cause of cardiogenic shock can be an issue with a structure in the heart, like valvular stenosis or certain dysrhythmia. There's an interruption in the body's ability to properly deliver oxygen and perfuse the body.
The clinical manifestations in a patient with a cardiogenic shock includes tachycardia, decreased blood pressure, decreased capillary refill, and a patient may or may not have a chest pain. Also, a patient will have a tachypnea, crackles, bronchi, cyanosis, and this is due to pulmonary congestion. A patient may also have a decreased urine output and a sodium and water retention, and this is due to the decreased renal blood flow to the kidney. A patient may also have a pallor, cool, clammy skin. Again, this is due to the decreased blood flow that is going to the skin. A patient may show confusion, they can be agitated, and also they can be anxious. And this is due to the decreased cerebral perfusion or buildup of toxins caused by the liver and the renal failure. A patient will have a decreased bowel sounds, may feel nausea, and may present vomiting. And this results from impaired motility and slowing of peristalsis.
All right, let's touch on labs and diagnostics for a minute. When it comes to cardiogenic shock, there's an increase in cardiac biomarkers, an increase in BNP, an increase in blood glucose, an increase in VOD. A couple diagnostic tests you might want to look at would be an EKG and a chest X-ray.
The pharmacological goal of the cardiogenic shock patient is to try and reduce the workload of the heart while optimizing cardiac output. This can be accomplished with vasopressors or vasodilators. Our first two drugs we will begin with are dobutamine and dopamine. Let's start with how these drugs are similar. Both can cause tissue sloughing if infiltration occurs, and so administration from a central line is highly recommended. They cannot be administered in the same line as sodium bicarbonate. Also, they should be stopped if tachydysrhythmias, which is an abnormal heart rhythm above 100 beats per minute, occurs. Dobutamine specifically is going to decrease afterload and increase the heart rate and heart contractility. This together will increase cardiac output. Dopamine, on the other hand, is more similar to epinephrine and norepinephrine. They will cause vasoconstriction and increase heart rate and heart contractility. We want to monitor for tachycardia over 110 beats per minute, heart dysrhythmias, and vasoconstriction. Nitroglycerin is used to dilate the coronary arteries and reduce preload to decrease the workload on the heart. Lastly, we have sodium nitroprusside. It's a potent vasodilator that will lower the afterload. Some nursing implications are to keep the infusion bottle covered, give only with D5W, and monitor serum cyanide levels for toxicity.
The main goal for a patient in cardiogenic shock is to restore blood flow to the myocardium by restoring O2 balance. Some nursing interventions are to ensure patent airway, administer oxygen to keep SATs at 90% or above, IV access, administer drugs as ordered, titrate as needed, insert a urinary catheter or NG tube, monitor neurostatus every 1 to 2 hours, continuously monitor vital signs and EKG, assess heart sounds for new murmurs such as S3 or S4 sounds, monitor respiratory status and urine output, auscultate bowel sounds every 4 hours, and monitor for abdominal distension.
Alright, we're going to do a quick overview of the pathophysiology of hypovolemic shock. Hypovolemic shock is going to occur when we have a large intravascular fluid volume loss. There are two different types. First, absolute hypovolemia. It arises when there is a fluid volume loss outside the body, such as hemorrhage from trauma or GI loss from vomiting or diarrhea. Next, relative hypovolemia is when there is a fluid shift from intravascular to extravascular, also known as third spacing. Some examples include plasma loss from a burn or ascites buildup from those with liver impairment. When we have a loss of circulating volume, whether it's from absolute or relative hypovolemia, there's going to be a decrease in venous return to the right atria, also known as our preload. When there isn't enough preload, our stroke volume, or the amount of blood being pumped from the left ventricle, is going to decrease. And with this, we will see a decrease in cardiac output. This decreased cardiac output is when the clinical manifestations rise as the tissue perfusion decreases.
Let's also discuss labs involved with hypovolemic shock. There would be a decrease in hematocrit, a decrease in hemoglobin, an increase in lactate, an increase in urine-specific gravity, and an overall change in the client's electrolytes.
The patient's response to acute volume loss depends on a number of factors. This includes extent of the injury, your age, and your general state of health. Patient who loses 15% or more fluid loss will show signs and symptoms of hypovolemic shock. So with hypovolemic shock, you've got low amount of blood in the vascular space, and your heart tries to pump blood to the organs, but the organs are not getting enough oxygen because the system does not have a lot of blood in it. So this results to decreased preload, decreased stroke volume, and decreased capillary refill. A patient can also show a tachypnea, which is an early sign, and a bradypnea, which is a late sign. A patient may have a decreased urine output due to decreased renal blood flow to the kidney. You will also see your patient to have a cool and clammy skin, and that is from the vasoconstriction. The blood is diverted away from the less essential organs, such as the skin. As a result, their skin will feel very cool. Also, you will see a patient to be pale, and this is due to excessive blood loss. A patient may show confusion, agitation, and they can be very anxious. And this is due to the decreased cerebral perfusion. And lastly, they may have an absent vowel sound.
When talking about the pharmacological needs of the hypovolemic shock patient, we need to think about fixing why the fluid loss is occurring. This might mean stopping hemorrhage or treating a diarrhea-causing infection. To treat the fluid loss initially, the typical treatment is a 3-to-1 ratio of fluid resuscitation. We will be replacing with 3 milliliters of iso or hypertonic crystalloids, such as normal saline and lactated ringers, for every 1 ml of estimated blood loss. This is due to the fact that they typically stay in the vessels and increase volume. Also, blood products like packed red blood cells to increase oxygen carrying capacity, fresh frozen plasma to replace coagulation factors, and platelets to control bleeding can be used as needed. Some nursing implications to keep in mind is the threat of circulatory overload and possible hypernatremia from saline solutions. Lastly, we have albumin, the large protein colloid molecule. It can be used to rapidly increase volume, and it's going to be particularly useful in hypovolemic patients with liver disease.
The main goal for a patient in hypovolemic shock is to stop fluid loss and restore circulating volume. Some nursing interventions would include ensure patent airway, administer oxygen as needed, IV access, administer IV fluids, blood products. You'll need to type in a cross match. Monitor neurostatus, respiratory status, heart rate, and rhythm, and sounds. Monitor vital signs, EKG, urine output, and ABGs. And auscultate bowel sounds and assess for distension.